Yeah, so for simple consultations, we've identified 5 different types. If you go to on Google, if you Google PLAB2 GRIPS, you will find a website called stefo.com, and they have a really nice description of some of the different types of GRIPS, right? So I've added a few extra ones just so that everything I've seen in the scenarios for simple consultations is covered. So this is the general structure for all the simple consultations. You may not need to, use each section. There may be some times where you don't need to do any further investigations. You've already got the definitive diagnosis. So it will vary, but you need to pick and choose from these. Everything that you will do will have some element of this. Right, so Stefo, the website that talks about GRIPS, it talks about 2 different types or 3 different types of GRIPS. And the first one is first presentations. And the second one is an admitted or follow-up patient. So it's like a second presentation or a follow-up. So instead of organizing like that, I've organized it instead as a blind consultation and orientated consultation. The reason being is that from what I'm hearing is that examiners want you to acknowledge that you have some information written in the task before you enter the cubicle. So you'll have, for example, if it says Mr. Smith has presented with XYZ, he's presented with chest pain, take focus history, assess and discuss management with the patient. You need to acknowledge that when you enter the cubicle and start talking to the patient. You shouldn't just say, how can I help? As if it was a blind consultation. The only time where you should just say, how can I help, is if it's a blind consultation. And so there are times where you'll need to, just mention, I understand that, you've been having some problems with your knee. And then you can go on and, say, could you tell me a bit more about, what's been going on? So acknowledge the information that you have. Let the patient know that they, what you know. So that's why I've split it into blind and orientated. And the orientated includes the follow-up and admitted, because with follow-up and admitted, they'll always orientate you with information in the task. So I've just added this extra one here. So we'll go into more detail about how to go over those. Then we've got the anxious patient. So this is the person who comes in. I think most of the scenarios are related to their children. So how's my child? Or how's my son? They're just adamant they want to know how their son is before you've been given a chance to introduce yourself or say anything, as soon as you walk into the room, basically. So you need to be prepared for that, so it doesn't throw you off. Because then what can end up happening is you get thrown off, you address their question, and then you get a bit disorientated and you start off in the wrong place and you miss out some important information, or like you miss out to ask the identity checks, for example. Or you'll miss out another part of the GRIPS, right? So you need to have a plan for how to approach those in the exam. Similarly, with the uncomfortable patient, so they can be in pain or breathless. So you need to pick this up. So you need to pick up the cues, the verbal and non-verbal cues. If they're in pain, they'll be wincing and making noises and things. So you need to acknowledge that. Don't be too rigid in the structure. Think, okay, this is a GRIPS for common conditions like renal colic is a common one for severe pain. I think what's the other scenarios for pain? I'm not sure actually. But breathlessness, there might be some COPD patients who are breathless with an exacerbation, or somebody with acute pulmonary edema. They're the kind of things. Now, breathless will also be covered in your kind of SimMan stations as well. It's the same similar kind of approach, but you do also get them in the simple consultations as well. And then the virtual ones, telephone and video. So yeah, important things to bear in mind: is it an expected call or is it an unexpected call? Has the patient called in, for example, to the GP surgery and is asked to speak to a doctor, so they're waiting on the line, or have you just called them? And if you've called them, was it expected or unexpected? So they're pretty much all the different types of scenarios that we've identified. So let's get into the first one. So this is your blind consultation. It just says talk to the patient and address the concerns. No other information is given to you apart from maybe the name and age. So by the way, I've written a handshake here, but because of the COVID policies, probably I don't think you're allowed to shake hands now. Mistake me if I'm, let me know if I'm wrong, but I don't think you can shake hands in the exam. So ignore that. But you can build rapport in other ways, right? So, for example, what would you like me to call you? Is Mr. Bloggs okay? Kind of thing. So that's another way of building rapport. And obviously, with your body language, you want to have a nice, welcoming open, friendly body language as well, and a nice tone. And remember to wait for a response before continuing. Don't go straight into your whole GRIPS without assessing the situation, seeing there might be something that needs urgent attention. So yeah, nice and simple first one. So this second one, this is very important, I think, for this exam. Honestly, like just having a structure for these kind of scenarios really, it makes your consultations just seem not very good. It's a bit not fluent. And you are marked on fluency, so it's good, especially for the beginning of a consultation. It's good to make a good impression, and I think a lot of your marks for fluency will come from the beginning of the consultation. So definitely for these scenarios. So there's 3 different types, right? Follow-up, admitted, or a first presentation, but you've got a bit of information. So that's that first one there, right? So you need to approach this first one here a bit different to the follow-up and admitted patients. So same as before, but for the purpose. So we've got the 3 Ps, right? I think other the academies and the courses and stuff, they use a lot of them use the 3 Ps as well, but I'm not quite happy with the way they've structured them. I don't think it lends to a fluent conversation, because, for example, they put the prior understanding in the middle, and that's really your chance to give them an open question, the opportunity to talk and for you to listen. So you really want to end your GRIPS on an open question, right? So if it's not, obviously, if it's a presenting complaint like this first one, then you end it on the, the presenting complaint. Could you take me through what's been going on? So I understand that you've been having some troubles with your knee. Could you take me through what's been going on? Or I understand that you were admitted yesterday with a fall. Can you take me through what happened? Or I understand, so for example, if it's a follow-up, I understand that you were admitted yesterday with some pain in the abdomen or pain in the tummy. So we're on the same page. Can you tell me a bit more about what's happened so far? And then they can just take you through everything. So start off with the position. So where are you now? Okay, so you're on follow-up. It's a follow-up consultation. It's a consultation for test results. They've been in hospital for X number of days. And what do you intend to do? So that's how I like to start off the purpose. Where are we now? What's the situation at the moment? And what's the plan for this consultation? Okay, so paraphrase task, that's the plan for what we're going to do today. And getting permission. And then finishing off with an opening question. So either the opening question that's going to depend on whether it's a first presentation or not. If it's a first presentation and it's just that they've given you a bit of information, then I would use this one. Could you take me through what's been going on? Or could you take me through what's happened? Say if it's an incident, like a fall or a seizure, for example. But if it was a follow-up or not a first presentation, so admitted patient or follow-up, then I think this might be more appropriate. So we're on the same page. Could you take me through or tell me a bit more about what's happened so far? So that's my kind of approach that I've got to. I'm always changing it though, refining it, but I think that works for me the best is make sure that we finish on an open question. And the same, by the way, for when you're exploring the symptoms, using Switch-ups or Socrates or Fodipara, or when you're doing the incident history, you should always end with associated symptoms so that the consultation flows nicely. So in the same way here, you should end with an open question. This is for the patient to start, talking, and for you to listen, to get everything off their chest and not to interrupt them. So that will be this part here. So this third one, anxious patient. So I think we've got a scenario today, an acute otitis media scenario, where someone's really anxious to talk about how their child's doing because their child's got a really high fever. So if you walk into that in the exam, you walk into the cubicle, they'll start asking you questions straight away. Won't give you a chance to introduce yourself. So you need to acknowledge what they're saying, not just ignore them. So the idea is acknowledge, I can see that you are worried about your son. I'm here, or I'd like to talk to you about your son. And then apologize. I'm sorry, but can I quickly check a few details first? And then can you confirm your name and age or date of birth, whatever's written in the task. If they give the date of birth, ask for date of birth. If they give the age, ask for the age, and confirm the relationship. And then move straight onto the opening question. Don't do all of this stuff here. I would move straight here because they're very anxious, and so we want to give them an opportunity to talk. straight away. So I would, fast track straight to the opening question here, and then so they can get everything off their chest, and then don't interrupt. The GPs call it the golden minute. Let them get everything off their chest, so they feel like you've understood them and you've given them a chance to talk, and then they're going to be much more patient to give you the information that you want. So GRIPS types 4. So this is the pain one and breathlessness. So again, it's the same kind of structure. You need to acknowledge when they're really anxious about something or they're in a lot of discomfort. It's not appropriate for you to be continuing on with the consultation. You need to address that. Now, it may be that you're not going to give them painkillers, but you still need to acknowledge that they're in pain. So I can see that you're in pain. Are you comfortable to talk, Miss X? If she's comfortable, she's like, oh, okay. Again, use your own judgment, your own clinical judgment, if they are comfortable enough to talk, as well as what they say. And then assess. So in this case, assessing the pain score. When we talk about the breathlessness one, we'll be assessing their observations. Most importantly, the oxygen saturation, the pulse oximetry. Or it may be they give you a Muse chart in the station for some of the stations. And if it's one of the ABCD, one of the SimMan stations, you might want to look at the cardiac monitor. But it's the same kind of approach. So if you were to score your pain on a scale of 1 to 10, 10 being the worst pain you've ever experienced, what would you score it? And she says, oh, it's an 8. Okay, I'm sorry to hear that, Miss X. I'd like to ask you a few questions just to help us get to the bottom bit and help us manage this pain in the most appropriate way. Try to be as quick as I can. Is that okay? If she's still kind of insistent, which in a lot of the scripts they're told to still be insistent until you offer them painkillers. So you will need to go through all these steps. But don't, if she says, yeah, I can continue, that's fine. That's fine. That's I'll bear with it for a few minutes. Then go straight into consultation. Don't force these upon her, but don't force the painkillers on her. But you've got them kind of in your back pocket to use if you need them. So the next one would be to explain the rationale. So Miss X, I'm worried that if I offer you a painkiller, it could mask important symptoms or examination findings. Would you be able to bear with me just for a few minutes while I just carry out a quick assessment? If no, proceed to the next step. Okay, Miss X, I'll give you something to help with the pain before we start. But can I just do a quick couple of safety checks first? Do you have any allergies, any heart or lung conditions? And what have you taken so far? Have you taken anything so far for the pain? Establish the timings and the dosage and everything. And then you might want to point to the examiner and explain to the examiner, since my patient can't continue consultation, I would like to offer a painkiller according to the analgesic ladder. So, obviously, if they've got any kind of contraindications to medications, if they are on omeprazole for peptic ulcer, then it might not be appropriate to prescribe non-steroidals. But yeah, so but I think for the most part, there won't be any contraindications, and they do expect you to kind of do all these checks. Really do try and continue the consultation without giving painkillers. So don't give painkillers straight away. That's, I think, a misconception in a lot of the notes, is that that we should be giving painkillers straight away. So we notice that they're in discomfort, and that's not the case at all. Especially for things like intestinal obstruction. It can really mask the symptoms and the findings. So we want to try and get that assessment in as quick as we can first. Next one. So this is the breathless patient. So I think the scenario I've seen for this one, I mean, we haven't got one in this presentation today, but I think I've seen one. I think it might be heart failure. Yeah, acute pulmonary edema. I think he wasn't taking his furosemide tablets or something. So he presents with acute pulmonary edema, so like an acute on chronic presentation of heart failure. And yeah, so you would need to go through this kind of and they give you a Muse chart as well. So the Muse chart, the Manchester Early Warning Score chart, that's just a chart that shows all the observations, right? And so you will find that in the cubicle, and there'll be a special note on there in the task that says there's a Muse chart in the cubicle. So you will need to have a look at that, because you'll see that he's breathless. And so you ask him, you'll acknowledge it. I can see that you're breathless, Mr. X. Are you comfortable to talk? If he says no, or your clinical judgment suggests that you need to assess his breathing, so move on to the next step, which is assess his observations. So in the acute pulmonary edema one, there'll be a Muse chart. In the SimMan stations, there'll be a cardiac monitor to be able to check the oxygen saturations and the respiratory rate. And then according to the oxygen saturations, proceed to the next step if they're low. So do a quick check, COPD and smoking, those two. Obviously, if a patient has COPD, they know what COPD is. Patients who don't have COPD, most of them won't know what COPD is. But if they do have it, they know what it is, and that's the most important thing. So they would alert us at that moment, and then proceed to speak to the examiner. So since my patient's hypoxic, I'd like to give him high flow oxygen or 15 liters per minute through a non-rebreathe mask, or if they've got COPD, controlled oxygen through a venturi mask, aiming for saturations of 88 to 92 before continuing with the consultation. Yeah, because you've got to address that before you start talking to him for 8 minutes, and then just continue with GRIPS again. And finally, virtual consultation. So if you are in Hardman Street, then you're going to have loads of telephone consultations. So definitely practice those. Practice doing consultations on Zoom or on the phone with people without video, so that you can't use any cues, any body language cues and stuff. So definitely practice, having really good tone, not being monotone, having a nice kind of variety of tone into your voice, being very expressive. That's good, I think, in those kind of consultations, and just being a bit more vigilant, because for example, if you are going to take a personal history, you're going to ask a woman about her periods, you need to be a bit more kind of explain things in a bit more detail than if it was face to face, because your body language, you don't have those verbal cues that you can give them. So you need to signpost meticulously, and similarly, you're not getting verbal cues from the patient either. So you need to ask them to describe things in a bit more detail because you can't see them. So if it's a rash, you need to ask them in a lot of detail. You can't just ask them to point to where the pain is. You need to ask them to describe exactly where it is. So yeah, so there are other things to bear in mind, but generally for introducing yourself, which is the main thing really that I think most people are concerned about, we want to be careful, because especially there are some telephone consultations, which you can do one today actually, which is a sensitive topic. It's pap smear results. So you don't want to be on the phone to her mother or somebody and assume it's her, and start talking about I'm from the gynae department or whatever. It's just not appropriate, even if it's it's nothing to hide. It's not appropriate. So definitely, and there are some stations where you're having to give HIV results and things like that. So that's where this particularly comes in, very important, not to introduce yourself yet until you establish who it is you're talking to. Now, you don't need to do a full identity check at the beginning. Just the name is fine. So if you're calling them, is this Mr. Joe Blogs? If they're calling you, may I know who I'm speaking to? And just watch your tone with that, because that can come across as rude if you don't deliver it in the right way. So tone is very important. And then introduce yourself. So if you're in a GP surgery, say you're from the Grange Farm GP surgery. If you're in the gynae department, and say you're calling from the obstetrics and gynecology department from the Ipswich Hospital or Manchester Hospital, and then go straight into, once you've identified yourself, straight into checking if it's okay to talk. So I wouldn't do it later on. I would do this first. Is it an appropriate time to talk? Obviously, if she's calling you or he's calling you, then it is an appropriate time. So you can skip that step. So, and then the next one, this is where you do full identity check. So for telephone consultations, we need 3 things: full name, date of birth or age, and first line of address. So you will need all 3 of those. So you need a bit more of an identity check than non-virtual face-to-face consultations, where you just ask for the name and date of birth or name and age. And then check the number to call back on. That's if the patient's calling you, really. That's where I'd say it's essential, but might still be worth doing. If I would still do it actually for even when you're calling, but I wouldn't say is this a number I can call you back on, because that you can, because you already did and it was successful. But is this the best number I can call you back on? I think that's probably the best thing, because they might have you might have called them on because on the system you might have had their home phone number, but they might prefer you to call them through by mobile. So it is a valid question to ask. I think it can provide some useful information. a lot of the time the records in the HS system won't have the right number, it might be outdated, might not be their preferred number. And then you might want to check the geography as well. I think that's if you're talking about a sensitive topic, or if you can hear that they're kind of at work and stuff. But I don't think that's really, I haven't come across any scenarios really that, unless anyone else has, let me know. I haven't come across any scenarios where you'd need to ask specifically where you're calling from. So obviously they will be available to talk. Okay,